This conference will now be recorded.
All right, welcome back, everybody. I apologize. I had something caught in my throat, and that's why we have two parts to the musculoskeletal system. So, we left off discussing critical fractures, which is the femur, the pelvis, any very large bones. And then when we're looking at when we're looking at the inside of those bones and then also the arteries correlated with it, we can see why there is such a large potential of blood loss associated with those femur fractures. So my assessment-based approach for my bone or joint injuries when I'm doing my secondary assessment is really honing in on the specific chief complaint that that patient has, palpate that injury site, expose that injury site, compare it to the unaffected side, look for discoloration, look for decap BTLS, and then go ahead, check CMS, and then splint into a position of comfort. So our signs and symptoms, again, it's really based on decap BTLS, which is going to be deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and then doing your pain scale assessment of your patient. So you can see this individual got a flat tire on their bike. Their left leg has a open fracture to it. So right there, that conducts our assessment findings and doing our differential diagnosis, because I can specifically see that that tib fib is fractured and it is exposed. So I'm going to go ahead and control that bleeding. Patient appears to be unresponsive. So another important aspect when we're dealing with traumatic patients is not to get the tunnel vision based on the specific injury that's presenting. Because when we arrive on scene and we see an injury site like this, I immediately hone in my vision to that open tib fib fracture. And I may forget or look over the fact that this individual appears to be unresponsive. They had a bike accident, patient's not wearing their helmet. Okay, I should be more concerned about C-spine precautions, airway breathing, circulation, and then I can come down to that open tib fib fracture. So another mnemonic that we can utilize when doing our secondary assessment for injuries to the bones and joints is the 6 Ps. So pain, pallor, paralysis, paresthesia, pressure, and pulses. So do your pain assessment, look for discoloration, look to see if that patient is able to move properly, and make sure that they're not feeling any numbness or tingling. Pressure, ask them if they feel pressure built up, because that's going to be from the swelling and the fluids building up. And then also checking for pulses in the distal portion of that injury site. As far as emergency medical care goes, use standard precautions. So that's going to be our PPE. Anytime that we have a significant event that might compromise the C-spine injury, go ahead and maintain C-spine stabilization. If we approach our patient, it's an isolated injury, they don't have any neck, head, or back pain, then we can go ahead and discontinue C-spine. ABCs, perform oxygen as needed, splint, CMS before and afterwards, and then go ahead and apply cold packs for the pain and the swelling. When we're doing reassessment, we're going to repeat our vital signs and we're going to be looking for trends. So what patients can't fake is their heart rate. So with pain, oftentimes we're going to see an increase in heart rate, respiratory rate, and blood pressure. So that's another good clinical finding, that when I splint that injury and I apply ice for it, let's say prior to that, their heart rate was 120 beats per minute, blood pressure was elevated, respiratory rate's elevated. Now I take their vitals again, and now heart rate is down to 100, blood pressure is 120/80, respiratory rate 19. Okay, those findings are indicating that I am treating this patient properly, because I'm starting to see the trend downward into that normal baseline set of vitals. And then we're going to check our interventions and recheck our CMS. Okay, diving back into our case study, EMTs Kyle Velez and Ellen Peterson arrive on scene. Glad to see that the first in engine has spread some sand on the surface of the ice to minimize chances of further injury. So we have successfully mitigated the scene safety aspects. The EMTs quickly complete a primary assessment, determine that the patient does not have a serious mechanism of injury or a likelihood of spinal injuries. Next concern is getting her out of the cold. Patient is doing a good job of self-splinting the injury for the moment. So they place her on the stretcher, load her into the ambulance before completing a modified secondary assessment. Kyle carefully examines Dominique's left upper extremity. She has a deformity and swelling above her wrist. Her radial pulse is present and strong. Distal motor and sensory function are intact. She also has a laceration on her left palm. So what would be some choices of splints that would be effective in this case? So immediately what I would be thinking about is utilizing the SAM splint or a moldable splint and formulate around the upper arm and the lower arm with that rolled technique so that she can grasp onto it. And then I'm going to perform a sling and a swath for that injured extremity as well. So what principles of splinting should the EMTs follow as they immobilize the patient? Splinting, we're always going to be doing this in a position of comfort where we minimize the movement to ensure that we are not enacting further injury on that patient. So splint in a position of comfort, make sure that we're splinting above and below that injury site as far as the joints. So basic splinting, so what we're utilizing this for is reduction of pain and to prevent further movement, and as a result, prevent further injury. So complications of splinting, we could see muscle, nerve, or blood vessel damage if we don't do it properly. We could go ahead and create a closed fracture to an open fracture, restrict CMS, we could increase the pain, or we could create a paralysis. So our general rules of splinting, checking CMS before and afterwards, big proponent of that. Immobilize the joints above and below the injury site. Cover all wounds, especially the open wounds. Align the injured limb if needed. Now, the only times that we align the injured limb is in the event that we do not have proper CMS. So we don't have circulation, we don't have motor movement, and we don't have sensation. Pad the splint for comfort. Hold traction until that splint is applied, and then treat for shock if necessary. I'm not going to dive too deep into this because we already did that. So splinting equipment, I've went through these. We got a wide variety of different splints. It all depends on your EMS agency and what they carry, what their medical protocols are on that rig. So here's an example of that hair traction splint. And for a full demonstration of how that's utilized, reflect back on the EMT skills session playlist and then select hair traction splint. I am going to be going over this because I was not able to find the proper vacuum splint application. So again, what a vacuum splint does is it has beads and it has air inside the vacuum splint. And so you apply it, you draw out the air, and then the beads actually formulate around that injured extremity. So these individuals, they check for CMS. Okay, we have a deformity to the left radius and ulna. I attach my vacuum splint and secure it. And then what this individual is doing is they're drawing out the air out of that vacuum splint. And then as a result, those beads around that splint are going to form around the injury site. Another example as far as improvised splints that I didn't touch on in great detail during the skill sessions. So an improvised splint, we can utilize pillows, we can utilize blankets, magazines, books, 2x4s, what have you, whatever we can utilize in order to splint that injured extremity to make sure that the movement is no longer getting there. So other hazards of improper splinting, so we already went through this. This is all of the same contraindications or same complications that could create it. And then also the big one here is delayed transport. So when we're splinting long bone injuries, check CMS, align if necessary if the CMS is compromised. Do not release traction until splinted. So specifically, this is in relation to our closed isolated femur fractures, and then reassess after that is completed. Another example of that vacuum splint, you can see with the air drying out that it's starting to mold around that extremity. So when we're splinting joint injuries, we're going to go through the same concepts. Be doing your secondary assessment, looking for pain, checking for CMS. So this individual dislocated their right knee while playing basketball. I checked CMS. Looks like these EMTs are big fans of the vacuum splint. They applied the vacuum splint in a position of comfort, and then they rechecked CMS. Traction splinting. Traction splints can be unipolar or bipolar. Most organizations don't carry the traction splint that you can create traction on both femurs at the same time. Remember, femur fracture, extremely painful. Those bones will collapse and the tissue will collapse on itself. Some contraindications for splinting if an injury is within 1 to 2 inches of the knee or the ankle. Knee has been injured, hips injured, pelvis, or there is an open fracture. So those are all contraindications. Specific traction splinting are going to be done on the femur fracture. So pelvic fractures, a lot of pain, significant bleeding. Most of the time this is going to be internal. So we could use commercial binder splints, which I showed you with that SAM splint, improvised splints, or the past Garmin pants. They still talk about these. They're the pneumatic anti-shock Garmin pants is what PASG stands for. They're big coverall pants. You apply them and then you start increasing the pressure within the air. That is not commonly used anymore because there's a lot of negative ramifications behind that. But there we can see that commercial pelvic splint. Another thing we got to be very concerned about with splinting is compartment syndrome. So with compartment syndrome, when we have pressure built up within that injured area, if there's so much force impeding on that injury site, from those anti-shock Garmin pants, and this is why we don't use them anymore, it can create compartment syndrome. So the tissues are being cut off as far as circulation goes. Blood begins to start pooling, and as a result, the toxic waste from normal perfusion is not actually being eliminated from the cardiovascular system to the respiratory system. So some signs and symptoms that we could see with compartment syndrome: severe pain or burning sensation, decreased strength, paralysis, pain upon movement. Distal portion may also be negative at this point. So non-traumatic fractures, another thing we got to be looking out for. Pathologic fracture. So this could be just from a normal everyday routine where you're walking and that bone fractures, and that's a result of an underlying medical condition, cancer, osteoporosis, individuals who are prone to fractures. Maybe they have other types of bone degenerative disorders. So our case study conclusion: Kyle selected a padded, rigid splint that extends from the patient's fingertips to just below the elbow, carefully applies, secures the splint, then applies a sling to immobilize the elbow. Reassesses the distal pulse and CMS. Hospital Dominique is diagnosed with a fractured radius and ulna, and then she will get cleared. So our summary: remember, musculoskeletal injuries, they involve fractures, sprains, strains, and dislocations. Some fractures can be classified as critical, specifically our femur and our pelvis. EMT management of those injuries prevent further complications by splinting, and with pain control. Lots of different splints out there. It all depends on what your organization carries. Be familiar with all of them throughout the duration of the class. So that does it for musculoskeletal injuries. Thanks, everybody.